Hello, I'd like to welcome everyone to the IBM Watson Health Executive Webinar Series. Today's presentation is titled Our Focus on Patient Satisfaction, presented by Frank Panzarella, VP of Operations, Martha Suckenberg, Senior Director of Health Center Operations, and Brenda Ferrero Hansen, Population Health Management Specialist of the Bassett Healthcare Network. Before we begin, I'd like to review a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize and expand this panel by clicking on the arrow in the upper right corner. Second, you can submit questions using the question panel located near the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation. If your question was not answered, we will respond to you individually after the event. Next, all registrants will receive a copy of the presentation and a link to the recording within 48 hours after the webinar. The information will be sent to the email in which you registered with. Next, I'd like to introduce Frank Panzarella. Frank is VP of Operations for the Bassett Medical Group. Since 2008, he has been the executive leader for Bassett Medical Group's professional staff of 440 providers and 900 employees. He is co-chair of Bassett Medical Group's governing body, which directs operational and strategic initiatives. Prior to working at Bassett Medical Group, Frank spent 7 years in progressively responsible positions at Partners Healthcare. He holds a Master of Health Services Administration degree from the University of Michigan. Today, the team from the Bassett Healthcare Network will be showcasing their best practices for improving patient satisfaction and more. Frank, the floor is yours.
Thank you very much. Greatly appreciate it. Thank you for that introduction. That sounded wonderful, but really the team that's with me today is the team that really has been boots on the ground and done the yeoman's work in what we're going to present today. I get the pleasure of being able to share with you some of the highlights of that and be able to sit here with them as they represent some really fantastic work here at Bassett in partnership with IBM Watson Fitel. The objectives for today are to share with you some best practices for improving patient satisfaction linked to our use of the IBM Watson Fitel Outreach Solution, give you some information regarding our experience with data integrity and the solutions that we've used to help close care gaps. To provide a bit of background on the Bassett Healthcare Network, we are an integrated delivery system based in upstate New York. We cover a geographic area of approximately 5,600 square miles, which is roughly the size of the state of Connecticut. We are a rural-based provider. Our mission statement really is focused on rural populations and working to advance the health care of those rural populations through excellence in the continuum of care, through education, academics and education, and pursuing health research. Organization is currently comprised of 6 corporately affiliated hospitals. We have skilled nursing facilities within our care continuum. We have a large number of community and school-based health centers, currently 20 school-based health centers and approximately 30 plus primary care sites, and an additional about 10 or so multi-specialty or specialty locations. We have home health care as part of our care continuum as well, along with DME companies. We are an accredited medical school campus of the Columbia College of Physicians and Services, and we have a number of other health partners in various related fields. We are comprised of approximately 530 employed practitioners, which represents about 480 actual FTE practitioners, physicians, and APCs across our network. And I would say that about 25% of those are in the primary care arena. Bassett has been a story of tremendous growth over the past 30 years, really a true model of the hub and spoke system, and really forward thinking in terms of the need to build a network of health centers, community hospitals, all centered around a tertiary care facility, focused on taking care of a broad population, a very dispersed population. In 1984, we were one acute care hospital based in Cooperstown, New York, a town of only about 1,900 individuals. We had a health center, a tertiary health center, providing a pretty broad mix of services, 180 beds, and services that range from Da Vinci robotics, now open heart surgery, etc. From '84 to now, we have dramatically expanded, as you can see, and really have built a comprehensive integrated delivery network to position ourselves for taking care of populations, the rural health population in particular, and have been quite well positioned to advance things like patient-centered medical home and to begin to enter into risk-based arrangements. We are a Medicare shared savings program, Track 1. We also have an accountable care approach with our local payer in upstate New York. And we are part of a Medicaid Health Home project as well that has risk-based components to it, population stations. And New York State is also underway in year 2 of a major DSRIP, a DSRIP being a Delivery System Reform Incentive Program that is again driving us towards different ways of providing care and really trying to transform our healthcare system. And FITEL has been a big part of some of that early work, particularly around patient-centered medical home and preparing for caring for our patients in a different way and really understanding their needs. In that regard, the need at the time, the problem essentially that we had was looking for a way to really effectively engage our patients and our population in getting them to return to our offices, to return to the site of care, to get things that they were overdue for. We had a rapidly expanding and growing network of practitioners, and we wanted to leverage that capacity for good. We obviously also wanted to leverage that capacity to ensure it was financially sustainable. So we wanted to bring the volume of patients in to support the financial sustainability, but we wanted to do it in the right way. We wanted to bring in patients for the right reasons that would help, that would actually mirror or would integrate with our overall mission and our goals for our organization and where we were moving in terms of managing the health of our population. And FITEL Outreach really allowed us to accomplish both of those goals. At the same time, we wanted to both maintain and actually advance our patient satisfaction scores. And one of the things that one of our hypotheses and one of the things that we heard from patients is the more that we knew about them, the more that they had a sense that we were watching out for them and that we were working hard to help keep them healthy, that would be something they appreciated. And I think that is also a need that FITEL has helped us to fulfill. And then very important as well, we didn't want to implement a system that didn't have the full support of our practitioner base. We wanted them to be a part of the why and the how right from the very beginning, and to ensure that they were supportive and understood both the effect and the impact of this solution, and really embraced it as a way to help them accomplish what they wanted to clinically. So from this base, we scanned the landscape, and at that time, and we've been live on outreach now for 2 years, but prior to that, we had really looked at different solutions, and we were an existing Televox customer, for instance, and they had a similar solution that they had at the time. But in surveying the landscape and really looking at who the industry leaders were, it was pretty obvious that the IBM Watson FITEL solution made a lot of sense to us. So we actually, even prior to starting a pilot group, we really engaged our providers, got them involved in the selection process. We brought them in up front to look at the why and the how. So what was the real problem or opportunity we were trying to address, and how might this solution work, and allow them to really get comfortable with demonstrations of the product, understanding how it would fit with their practices, what the key success factors were. So we knew from the outset that we had all of our primary care leaders fully informed, engaged, and supportive of rolling this out, because without that, the ability to get consensus on the protocols, the support of it when things might not go quite perfectly, we would lose that very quickly. So that was a critical part of it. And then also starting out with a pilot group, essentially saying, okay, to make sure that we understand all the operational implications of this with our staff, as well as our patient reaction to it and the effectiveness of how it will work with bringing the right patients in. We started with a pilot with key success factors to make sure that we could tell the right story, that we could convince and ensure ourselves that what we had implemented, we did it the right way and that it was having the desired effect. I want to turn it over to Brenda, because Brenda was really critical in this implementation, along with a host of others behind us, that really began working on the engagement of staff and practitioners well before the go-lives.
Good afternoon. Prior to the time that those initial demonstrations were shown to providers, we had 21 primary care physicians from multiple health centers who volunteered to pilot the outreach program. Their staff received initial training, and then following the pilot, training continued for all of the staff who would be using the system. The initial training was in the form of a live webinar, and then online training was made available on Bassett's internal training website and also available on the Vitel website. Physician leaders were the ones who chose the protocols that they wanted to target for reminders about chronic and preventive gaps in care. And they were shown quality initiatives for DSRIP and medical home and CMS, and then also the Vitel protocols. And this allowed them to choose protocols they were clinically comfortable with, and also to align them with the quality initiatives. And as Frank said, we were trying to keep providers happy, so it was important to have them involved in especially this part of it. And I think they were pleased to see that their efforts were made to align those multiple initiatives, and that Vitel was a tool that would allow them to accomplish this. During this pilot phase, the focus was on validating the data. Did Vitel have the data that they needed to generate calls that were accurate? We knew it would be important to prove that the system was credible in order to get future buy-in from the remaining providers and the support staff, and most importantly from the patients. The initial implementation went smoothly, and we proceeded at short intervals to add all of the primary care providers, women's health, APCs, and most recently our school-based health center providers. And currently we're up to 118 active providers on Vitel. Our pre-go-live patient outreach campaign, we engaged multiple initiatives to educate patients. We had press releases to the local newspapers, and this was a lot of local newspapers because we cover such a large area. An article in our quarterly newsletter that is mailed to area households. We did radio ads. We created pamphlets that we started handing out prior to the go-live. As patients were registered for their office visits, they would be handed a pamphlet. And these pamphlets were available in our waiting areas. We created posters for our waiting rooms and our exam rooms. We added information about this new service to the homepage of our patient portal, and continued to train the staff on how to educate patients about this new service. Continuing to explain to the staff that it was important that patients understand the purpose behind these calls, which was to get them the care they needed based on evidence-based protocols, and that these weren't just another annoying automated phone call. We provided scripting to those who were registering patients, that when they handed the pamphlets to the patient, they would say something like, you know, this is a new service we want to tell you about that we are providing to our patients. And we communicated to staff specific contact information for when they had questions and concerns. Handling patient feedback. In June of 2015, a part-time position of a population health system specialist was created. And that's me. That's what I do. And I'm responsible for planning and organizing and implementing the FITEL outreach program. I make sure that new staff are trained. I make sure providers who leave Bassett are deleted from the outreach program, and that as new providers arrive that we get them added so calls start going out on their behalf. I make sure that we are effectively utilizing the system. You know, look at, are there enough gaps in care being identified to allow for the maximum number of phone calls to go out daily. I establish standard work processes among daily users of the system. And probably most importantly, routinely monitor that the system is functioning the way we want it to. And I do this by randomly selecting calls to check for correctness. And this requires working closely with the FITEL staff and with our users. I send out a monthly newsletter to our users, you know, answering questions that have come in during the month, and this keeps them engaged. And we also have recently completed a new round of refresher training. We have over 200 users at multiple locations, and these day-to-day users, these people who are taking the calls from the patients, are the ones who most often hear the feedback from the patients. So I created a standard way for the users to communicate with me, and that's with one easy email address that they can type in that actually goes to 3 people. And it's primarily my responsibility to handle those emails, but they can be addressed by the other 2 if I'm away. Plus, this allows the other 2 to constantly be aware and up to date on what our patients and staff are concerned about and how things are going with the outreach program. So when I get these emails, I investigate and I report back to the person who sent it to me, and they in turn can respond to their patients. You know, this sort of enhances their relationship with their patients at their health centers. And getting this feedback allows us to identify concerns and consider changes to messages and protocols, really any aspect of the program. One example is, you know, I heard from multiple moms that they did not like having their young children come home from school and listen to a message on their answering machine that mom needed to have a pap smear. So we were able to change that message, and we simply took out the words pap smear and substituted a preventive service. So when the patient gets these calls, you know, they can just call the staff, and the staff can tell that it was a pap smear that is the gap in care, and can schedule the appointment accordingly. I also received feedback from providers who had concerns about the mammogram message for young adults aged 40 to 49. With the help of our provider leaders, the message was re-scripted to just encourage these women to have a discussion with their provider to determine when they should have a mammogram, rather than just the message saying you haven't recently, if you haven't recently had one, call us to schedule. Data integrity practices. As with the data validation that we did during implementation, we continue to validate and monitor whenever changes are made. If we add and delete providers, you know, we're looking to make sure that this has been done, that the calls are going out. Have these added providers been assigned the correct protocols? Are the correct number of calls being made? And it's really imperative to stay on top of these things, again, to establish and maintain the credibility of the program. I don't think I can stress enough how important that piece of it is. But by checking this data, it also allows us to be proactive and to identify issues early on. And an example of this would be with the asthma protocol. We identified early on that FITEL was considering intermittent asthma codes as well as persistent asthma codes when determining what patients were eligible for a reminder for an asthma gap in care call. This created an opportunity for us to remind our providers of the need to code appropriately, as well as request Vitel to look at only the persistent asthma codes. We did not want patients to get calls that they needed a follow-up visit for asthma if they had only been seen once for bronchitis. And asking questions, I don't think there is ever a dumb question. Questions create the opportunities to identify what people are concerned about and to uncover and resolve issues. Plus, again, it keeps our users engaged. So I think we'll go to Martha now, who's going to talk about physician acceptance.
As Frank had mentioned earlier in his comments, we really began with clinician stakeholders early in the adoption process and the decision-making process of the Vitel outreach program. And it started again with demonstrations. We have a group called the Primary Care Council with all of our chiefs, nurse leaders, operations leaders, where information was really presented in detail about how the program would work, what it could do for us, how it could be our first step toward population health outreach, and how it could help us really close gaps in care. I think all primary care clinicians like to feel that they have good internal systems in place for ordering preventive tests and recalling patients with chronic diseases. But I think when we were actually able to show what those gaps in care were, they were very supportive of wanting to advance this program, and particularly also when they looked at the evidence-based protocols. They aligned very much with a lot of the practices they had in their day-to-day clinics. They were familiar with the standards, the national standards such as U.S. Preventive Task Force, and they were comfortable in using them. So I think that really helped with the program. And the thing that we found to keep the provider interest and to continue to get their support is showing them the outcomes of the program. And we'll show you in a minute a dashboard that we have, but really being able to show them on an ongoing basis how many patients are we reaching out to, how effective are we, and how are we able to drive overall outcomes.
I think early on as well, we with some of the data available to us from Vitel itself and the tracking that our staff did of opt-outs, for instance, we were able to go from the one-off, a patient said to a provider, "I hate getting these phone calls," to the provider saying, "Well, all of my patients hate getting these phone calls." We were able to go back and with evidence say, "Well, we have done 400 phone calls to your patients, and we have had 2 people opt out from those phone calls." So that helped us to really change the dialogue with certain providers as well. One of the things that was really important to me that I mentioned early on was finding the right volume of patients to really look at not just bringing patients in, but working with our physicians and AP and advanced practice clinicians to understand who did we want to bring in, who were the patient groups that we most wanted to affect care with. And this is really where Martha, as well as our leader for patient-centered medical home, played a big role in working with those practitioners. And I think Martha can talk a bit about how these types of volumes really lined up. The other thing that we were trying to do was also leverage the system to look at practices that had a lot of growth. I talked early on about a lot of this growth that we've had, and just in the past 3 years, we have expanded the number of primary care practitioners in the network by about 20%. And as we've brought in those new practitioners, it's probably been about 50-50 physician and APC, but we've brought those practitioners into practices that had established panels. And those panels of an established physician were perhaps pretty full with very high booking ratios. So by turning on Vitel for that established practitioner, we were able to bring, from a care team perspective, bring the right patients back into the practice who those physicians wanted to make sure we're being cared for and bring them into the APC's schedules so they could get the needed care, the right kind of care, the right types of services for the health maintenance issues we wanted to take care of, while at the same time building a team-based approach and helping to establish that advanced practice clinician, NPPA, PA's panel of patients and build that relationship with the patient. And again, have the patient have a sense that we understood what was happening with them and an ability to reach out and to help them take care of their health. But I really want to turn it back over to Martha to talk about a bit more of the alignment of the types of care that we were trying to drive in.
I think building on what Frank's saying, for those of you on the line who are interested or pursuing patient-centered medical home, there's a direct alignment with the FITEL outreach program and the protocols, and also with patient-centered medical home and a key characteristic of the medical home being working on quality improvement, performance improvement, the measures it's working on, immunizations, preventive services, chronic disease management, all align with the FITEL outreach protocols. And we utilized our FITEL outreach calls to receive auto credit for some of that outreach, and also to help us drive the quality outcomes we wanted, improving our immunization rates, improving our chronic disease management, particularly of conditions like depression, which we'll talk about in a moment. But there was a direct alignment with the FITEL protocols and medical home quality improvement work.
Yeah. Oops, sorry. Really, yep. Sorry. For some reason I went backwards there for a second. So, as great as the solution sounds and as intuitively as much as it makes sense in terms of taking care of patients, we all have a financial responsibility to ensure we have sustainable organizations, and just unavoidably the question comes up of, is there an ROI on this solution? And I can tell you that it was certainly a question in our organization. I believed in the potential of it, but at the same time we wanted to validate that it really was driving results for us. We are fortunate that we have a small but pretty nimble and adept business intelligence team here, and we leverage ClickView, and we were able to have that team assemble a dashboard for us that pulls in on a monthly basis data from FITEL in terms of the outreach calls that were made, and it has a visit number. It has a way for us to link back to our billing data to look at actual compliance and then get actual net reimbursement for each one of those visits that was driven by a FITEL outreach reason. What you see in your screen right now is just a small snapshot from basically October. It's about a 12-month snapshot, so October of last year through current, just for the outreach reason of depression. And what we can see is in the last 12 months, we have successfully had 1,894 patients come in for 3,583 visits, resulting in net facility payments of just over $375,000 and professional payments of about $243,000 for a total of a little over $600,000. Now, these are net. This is actual net payment to the hospital, to our organization. And it's for both the outreach reason itself, so the actual visit for related to the depression outreach call, as well as additional potential payments that were made. So if there was a lab test or if there was something else that was done that's linked to this particular visit, we also can track credit for that. So this really gives you sort of that full downstream effect of bringing that patient back into your practice. As you can imagine, over the course of years we've been implemented, it's a multi-million-dollar total net impact, but even when we scale it back only to the net reimbursement for for the actual outreach reason, it still is a substantial $1 million plus impact to our organization. So this has really been a critical part of us being able to confirm within the organization the impact of this solution, as well as help us convince our medical group of why we need to sustain, to invest energy into the outreach solution.
I would just add to what Frank's saying. We had a particular interest in this depression protocol, and I also added this slide because it was very much aligned with our patient-centered medical homework, where we're starting to screen patients for depression, and this is a tough population to get them to comply and come back in for care. So partnering up with our medical home efforts along with the FITEL calls to really get this group coming regularly for care and following up with their medication regimen or therapy regimen was really important to some of our clinical work that we were really trying to accomplish. So I wanted to share this slide, and we do use this, while obviously very important for ROI, but also to see how patients are responding to individual protocols. We can look at this in many different ways. We can look at age ranges, particular locations, so it's very helpful to us in managing the overall program. I'd also like to just give you some sense of, for any of you that are working on quality improvement initiatives in your practices, you know it's very hard to drive improvement. And as that previous dashboard slide showed, you know, getting 1,800 depressed patients to come in for care is really good. We also attributed to FITEL another 3,000 women coming in for mammogram screening. We had 3,600 patients come in for pediatric wellness protocols in the same year period. And like many of you, I'm sure that you're eligible for incentive payments from your insurance carriers. And we found that in our first full year of FITEL implementation in 2015, our payments for incentives for pediatric preventive care went up $200,000. We really attribute this to our FITEL outreach programs. We weren't, you know, doing other protocols. We weren't doing other things to impact this. And this is really a win-win for us, both in improving our ROI, but also in getting these additional incentive dollars through this work. I'm going to let Brenda talk a little bit about our work with IBM post-go live.
Working through issues and concerns has allowed me to develop a partnership with our FITEL team. We have weekly meetings. I deal directly with a client care rep for resolution of issues, and we email back and forth all the time as needed, and always with prompt responses from FITEL. I receive configuration workbooks at least quarterly so that we can review them to be sure that our settings are always the way we want them to be. These configuration workbooks contain information such as the contract settings, which tells us how many active providers we have and what we're being charged. It shows us those outreach messages that are being communicated to our patients, so that we can be sure that the changes we've requested have been implemented. It shows us who the active providers are and which protocols they have active. We also receive operations and value reports monthly, and these reports show us the number of calls that were attempted and the number of calls that were successful. The estimated revenue from patients who made an appointment after the call, the return on investment, and you can even drill down to the practice level by protocol, by C codes, and we also receive information on the number of patients who opted out and why they opted out. There's lots of data here to evaluate, and it's important to at least determine what you want to look at each month and then do it. So back to Martha on different forms of communication to engage patients.
I think one of the things Brenda talked a lot about what we did initially to get patients ready for these FITEL outreach calls. And I just wanted to talk a little bit about what we're doing now to continue to engage patients. And we, at the hospital, do have a patient advisory council, and we've been trying to utilize that focus group, if you will, to get their feedback on new campaigns that we're trying. We just launched a couple weeks ago a flu campaign that they gave us some feedback on the scripting that we were going to use. So we are trying to use formal patient feedback opportunities, as well as the feedback patients call us with concerns, questions. We've updated the patient portal landing page, sharing our current metrics. How many women in the community have been screened for breast cancer? How many children got well child checks because of these calls? How many seniors got pneumonia vaccinations through this reminder system? So trying to show the value of it and keep people engaged and informed. We've also used a document that we send out to households in our service area called Healthy Decisions that allows us to communicate in more depth through articles about the program and feedback from providers, other patients.
Yeah, you know, one other thing on that I wanted to mention as well related to the impact of this. When you look at our Press Ganey top box score trends in September of 2014, our mean score was 70.5. That has dramatically risen to 76.5 at the beginning of this year with a consistent month-over-month trend. So we are seeing a translation of this and other efforts as well directly into our top box scores for CCAPs.
And these last couple of slides are just going to give you a little example of the types of communication we have. I talked a little bit about this. This is our Healthy Decisions newsletter that goes out to households, and really tried to feature information that we have regarding population health and medical home efforts. And the next slide will show an example of an actual article that we just put out. This came out in our fall issue, talking a lot more about our results, what's happening with FITEL and our population and medical home efforts, and that we're also looking for them to participate more in feedback surveys and really trying to get them to engage in that. I'm going to turn it over to Frank just for a summary and wrap-up of our results today.
Thank you. So hopefully you've enjoyed some of the detail that we've presented here on how the team has really progressed through making this a very successful initiative at Bassett over the past 2 years. So as we stand here now, 2 years later, post-go live, and we look back from that point of go live and the end of April 2016, we had more than 43,000 booked appointments that were all linked back to our FITEL solution and the automated calls. Only a 7% opt-out rate. 4% of that 7% has actually geographically left the area. So really it's the 2% number, only 2% opting out of wanting to receive these care reminders. That's really the number that is the one that is most meaningful. So again, we see that through our very specific efforts to understand how the solution's working, adjust our communication approach, ensure that we have extensive physician and advanced practice clinician buy-in and support for the solution, has allowed us to keep our patients very engaged in allowing us to leverage this tool to help them with their care and help them manage their care. We have been able to sustain and improve our booking ratios. So again, in terms of both practitioner satisfaction with being able to have a full schedule with the kinds of patients they want to be able to see and help take care of, as well as for our organization, ensuring sustainability, being able to have very high booking ratios. Despite increasing our overall capacity by 20% or so, we've been able to fill that capacity as we built it. In March of 2016, we actually registered the highest level of available hours ever in our history, and this is essentially how many hours are available in the schedule to be booked by patients. We had 28,000 available hours to be booked, and we were able to book 87% of that time. 6 months earlier, we had about 1,000 less available hours, and our booking ratio was only 85% of that lower number of available hours in our schedule. So as you can see, even in 6 months, in that 6-month period, we have continued to grow our capacity, and despite that growth, our ability to bring the right kind of patients in is outpacing the degree to which we're adding capacity in our primary care network. So to date, our total net collections, which is a 1-to-1 attribution, is 2.0 since the initial pilot. And what that means is the 1-to-1 attribution means just the visits that were driven by the actual outreach reason. The total net collections, which is all sources, both the net revenue from the actual visit for the actual outreach reason, along with ancillary impact or downstream impact, meaning like the actual x-ray or other tests that was ordered during the visit, or the labs that were ordered during the visit, or other care that took place within a certain time frame of getting that patient re-engaged. It's $10.4 million in net reimbursement to our organization over 2 years. So a very substantial and eye-opening impact for an organization that has a total annual budget of only about $400 million. That's a pretty substantial impact on considering the size of our organization. And with that, we will conclude our formal comments and move into a question and answer session.
At this time, you can submit questions using the question panel located near the bottom of the control panel. We will take time to answer as many questions as we can. We'll take a minute for the questions to come through in the queue. All right, we have a couple questions that have already come in. The first one is, what staffing changes, if any, did you have to make to support the outreach?
As far as our end users, we didn't have to add any additional staff. Staff did not find this particularly onerous to receive the calls from patients and to schedule the appointments. We added one part-time analyst, which Brenda's been talking today, and who's doing a lot of the day-to-day maintenance of the product on our side and the ongoing monitoring.
Okay, the next one is, what type of communication works best for informing your patient?
I would definitely say that you do need a multimedia approach. I think one approach alone is probably not adequate. I think obviously we were able to ensure that our patients got the information by giving them an actual pamphlet about the program. But I think all the other approaches, the portal announcement, press releases in all the local papers and radio ads, sort of setting the expectation, I really think that combination was very helpful in doing it well in advance of the start of the program.
We actually had our Director of Corporate Communications assist us with a formal communications plan prior to the launch of this, which was not just the patient communication, but also internal communication, because it was what our staff were going to say to these patients in the office when they came in on the phone, how our practitioners would characterize the program as well, were all critical components in communicating with our patients about the effort, what to expect, and why it was important for their health for us to be able to do this program.
I would definitely agree with Frank that having the staff and providers be advocates for the program is really critical.
Okay, the next one is, how did you revise your messaging after hearing feedback from your patients?
Well, Brenda had given the one example that we revised the mammogram protocol based on actually patient feedback. That age range of 40 to 49 women, there is some controversy of the benefits of screening early, depending on a person's individual circumstances. So we went to recommending they have a discussion with the provider about their individual risks and benefits, and that went over very well, I think, both with the patients and with the providers.
It also helped us to resolve some internal communication challenges because we do have different groups within our medical group that have different views on what standards should be followed for a mammogram. So our primary care physicians have a different view on this than our radiologists, than our women's health providers. So to make sure that they were continued to be supportive and consistent in messaging as well, that was another driver for us to have to change the messaging. And then we were also able to communicate differently internally. So we modified our message that way as well. It'd be nice if we could all agree on the same standard, but I think as probably many on this webinar see within their own organization, some of these national standards that come from different national organizations and are slightly different in terms of their protocol are difficult to get a large medical group to really agree upon and come to a single consensus.
I think the other thing we heard from our patient focus group was keep the message short. We often, as administrators, want to communicate a significant message, and really if we want the patient to listen to it, it has to be very succinct. And we had to work sometimes on wordsmithing the message to get it to brief but meaningful.
And once we have that proposed new message, I mean, the process was simply to provide that to Vital, and they have a team that would review it just to make sure that it meets all HIPAA regulations, and they just made the change.
We also had to do some internal work in terms of how we message things with our patients for when they actually called up. We have multiple points of potential phone call entry into the organization, and although we provide a phone number during the message, if they called back in during off hours and got the call center, we wanted to make sure that the message the patient was getting was a consistent one that didn't make them, that it didn't provide a perception that our staff didn't know why we had called them and what the issue was. So we had to do some work there as well to get so we made some changes internally in terms of our scripting and our approach and training. This is where Brenda's role as our specialist focused on Vital really comes into play, because she spends a lot of time looking at these gaps or where we have opportunities for improving our process and does retraining of our staff and ensures that we have that consistency, which is critical in how we message our patients.
Great. The next question we have is, how many different types of EMR systems were in use by the PCP practices added to Vital?
So we're fortunate that when we implemented in 2014, we were already up on Epic across all of our ambulatory sites. Bassett is rather unique in being a closed panel model, fully employed, integrated healthcare system. When we launched Fox, which is an affiliate of ours, they were up on a different EMR. They were up on McKesson. However, both locations drove the Vital solution not off of the EMR, but we drove them both off of our GEIDX billing information. And at the time we brought Fox up, they had been converted to GEIDX for their billing as well. So we were essentially leveraging the same data source for both organizations.
Next question is, have you thought about implementing an automated solution like this for post-discharge calls and setting up the follow-up appointment?
Well, so we're currently in the process of converting from GEIDX for scheduling, registration, and back-end billing, and that's actually a part of our conversation and focus related to that implementation of how to automate some of the processes on the discharge side for follow-up appointments. So we haven't made a decision of exactly how we want that to work yet, but it is part of our current conversation and planning as we look forward to April of this coming year when we go live with the Epic platform on the revenue cycle side.
Okay, regarding the implementation, how much time between go live for pilot 21 physicians and onboarding to 118 providers, a full 2 years?
It's about a little over a year, I think, before it was about the we brought the second pilot group on just after the new year, right? February? Yeah, so October was the first we brought the first group on, then we came on in February, then we brought on another group in spring, and then late summer we brought on yet another group. So it was sort of a phased approach, and it wasn't and some of it was because we were bringing on not primary care practitioners, but pediatricians or women's health providers. And then Fox is also part of that 118 providers, I believe, right? No, they're not part of that 118. So, but Fox was another phase as well. But it was about a year before we had the full complement of all of our primary care practitioners, pediatricians, and women's health practitioners up and going on the solution. And that includes I believe at this point, our school-based health nurse practitioners. We have 20 school-based health practices in 18 different school districts or 17 different school districts, and we actually, and they really end up serving as sort of the primary care practitioner for a lot of these kids in our rural health and our rural school districts, and so they have a panel of patients that they regularly see, and it was important that we be reaching out to that population as well, and to get those advanced practice clinicians up on the solution. So we do have them as well as part of that 118.
Okay, when handling processing patient feedback through the emails and phone calls, was it mostly a manual process?
Processing the patient complaints via email.
Oh, this is Brenda. I receive an email from the user, the person at the health center who spoke with the patient, and they would email me, and I would just do my little investigation into checking, maybe comparing the information between our medical record and our billing process to be sure the call, to be able to give the reason why the call was either accurate or inaccurate. I actually found very few that were incorrect.
What would you say your average volume of complaints are that you have to deal with?
Maybe 3 to 5 a week, and most of the time, as Frank said, the information is coming from our billing system and not from our EMR. So most of the time I find that the issue is that the patient received the service outside of the Bassett system, which our billing system would not indicate that.
Right.
But again, and still I would say maybe 3 to 5 questions a week.
Very small percentage given
Yes.
the volume of calls. We're doing 15 calls per provider per day. With 118 providers, that's a lot of calls compared to the complaint or questions.
Great, and that wraps up our Q&A session for today. I'd like to thank the team at the Bassett Healthcare Network for their time today. As a reminder, you will receive a follow-up email that includes this presentation and a link to the recording within 2 business days via email. Also, we ask that you take the brief survey when you log off the webinar to help us learn more about what was effective and what we can improve on for our future webinars. At this time, the webcast has ended. Thank you for attending, and we hope you have a wonderful day.